I thank the organizers to give me the opportunity to give this talk. And this topic of management of thrombophlebitis and chemotherapy extravasation, I feel is a very important topic because this is the side effects, or we can say complication of chemotherapy during or after the treatment, and one has to be vigilant. So, just few words about the superficial thrombophlebitis. It's a common inflammatory thrombotic disorder in which a thrombus develops in a vein located near the surface of the skin. The aim of treatment is to alleviate local symptom and to prevent the DVT or pulmonary embolism. This is very important because whenever there is superficial thrombophlebitis of more than 5 centimeter, a patient can develop DVT also. About extravasation. Extravasation is defined as the accidental infiltration of the chemotherapy into the subcutaneous or subdermal tissue at the injection site and can result in tissue necrosis. The damage can continue for months after the initial treatment, and it can involve the nerves, tendons and joints. So it can be so serious also. So the incidence is ranging from 0.1 to 6 centimeter when administered through a peripheral IV axis, but there is incidence of this extravasation when it is given through central venous access device also. The incidence is 0.26 to 4.7%. The sites most often implicated in extravasation injuries include the dorsum of the hands, foot, ankle, antecubital fossa, near joints or joint spaces, where there is very little soft tissue protection for the underlying structure. So these are some of the patient related factors. I think the important to note is the small and fragile veins, obesity and predisposing bleeding conditions, and lack of prominent veins. Cannulation or infusion procedure related. Untrained or unexperienced staff. This is typically happens when a junior nurse put the IV line, and especially in a patient who is going to receive chemotherapy. Multiple attempts at cannulation, unfavorable cannulation site, bolus injections, high flow pressure, choice of equipments, and inadequate dressing or poor cannula. I'll just come to the classification of drugs, just brief about the drugs which are known to cause extravasation. So there are 5 categories. These 5 categories are vesicant, exfoliants, irritants, inflammants and neutrals. The vesicant drugs are that can result in tissue necrosis or formation of blisters when accidentally infused into the tissue surrounding a vein. So most of these drugs are anthracyclines and vinca alkaloids. So this is the picture. You can say there is a blister formation. The second one is the exfoliant, which may have low vesicant potential, but these drugs can cause inflammation and shedding, that is peeling of the skin, without causing any underlying tissue death. And these drugs are cisplatin, docetaxel, liposomal doxorubicin, mitoxantrol, oxaliplatin. This is the example of this. The next category is irritants. The drugs can cause inflammation, pain or irritation at the extravasation site without any blister formation. And these drugs are bendamustine, bleomycin, carboplatin, etoposide, teniposide. This is the picture which is showing the inflammation. The next one, the category is the inflammant. The drugs that cause mild to moderate inflammation, painless skin erythema and elevation. These include bortezomib, 5-fluorouracil, methotrexate. The next category is the neutrals. These drugs neither cause any inflammation nor any damage. So most of the monoclonal antibodies as well as other drugs like asparaginase, bevacizumab, bleomycin, bortezomib. This is the same category of. So what are the grades? So grades are ranging from grade 1 to grade 5. Grade 1 is no extravasation. Grade 2 is erythema with associated symptoms, that is edema, pain, induration, phlebitis. Grade 3 is ulceration or necrosis, severe tissue damage. Grade 4 is life-threatening consequences, requires urgent intervention, and grade 5 is life-threatening condition. Manifestations of some commonly used chemotherapy drugs The commonly used drugs, the first category is the anthracycline, and these drugs are, I think you people are aware about it. It has the greatest vesicant potential compared to other drugs. And the lesions form slowly over the weeks and expand over periods of months due to tissue retention of the extravasant vesicant. So basically anthracyclines cause DNA damage. So they damage the cells and they go deep into the tissue. This is one example. Vincalculide is another common category. The commonest drug is vincristine, and it is known to cause a painful ulceration, local paresthesia and slow healing. And the erythema may be delayed for 1 to 2 hours and then even 3 days depending upon the dosage administered. The next category is the Taxane. Docetaxel, paclitaxel are the most often classified as vesicants. Most reactions consist of erythema, tenderness and swelling, but there are case reports that who had necrosis and skin exfoliation. Oxaliplatin are also have been reported recently having vesicant properties. So how to prevent? The important point is education and training among the nurses and physicians. That is a very, very important, I think, way to prevent extravasation. Appropriate vascular access. Appropriate access is the crucial for prevention of chemotherapy extravasation. It can be either through a central venous access or through the adequate peripheral vein. So it is very important you don't use the small or fragile veins and try to use the smaller cannula in a bigger vein. And whenever it indicated, please advise for the PICC line or central venous access devices. So peripheral arm assessment should be done before putting the IV line. Assess the location and fragility of the patient's veins. You have to see the age of the patient, presence of other medical conditions like diabetes, history of previous venipuncture, presence or absence of ecchymosis, previous hospitalization. Appropriate cannula and needle selection. This is another very important factor. Selection of the appropriate cannula type and size plays an important role. The recommended choice is to use the smallest size of adequate and appropriate cannula in the largest vein. And as far as possible, butterfly needle should be avoided. Patient education is very, very important. Patients should be instructed to report any discomfort, pain, redness, swelling at the infusion site. So not only the nurses and physicians, the patient also requires education when we start the chemotherapy infusion. So the patient should be informed about the class of the drugs, options of venous access, understanding the higher risk of extravasation whenever we plan a particular chemotherapy regime. Continuous monitoring is very important in the beginning and during the infusion every 5 to 10 minutes. And there should be extravasation kit available in the chemotherapy daycare center, which includes disposable syringe, cannula, cold hot packs, gauze pads, adhesive plaster, gloves, antidotes that can be used in cases of extravasation. What are the pharmacological drugs available? So we have dexrazoxane available. Dexrazoxane is basically used for anthracycline extravasation. So the data has been extrapolated from the cardiotoxicity caused by the anthracyclines. So the dose is 1000 milligram per square meter. It has to be used within 5 to 6 hours of extravasation. Very, very important. And then followed by 1000 milligram per square meter on second day and 500 milligram per square meter on the third day. And it is a recommended antidote for anthracyclines. There is another drug, hyaluronidase, which is an enzyme, degrades hyaluronic acid in tissues and promotes the diffusion in the extravasated agents. And it is recommended for vincalculoids, etoposide and Taxanes. Dimethyl sulfoxide, or we call it as DMSO, is another agent which is also being used and it is also recommended. So it has been shown that DMSO 99% was administered twice daily for a period of 14 days and there was no ulcer described. And this has been used for anthracycline extravasation and mitomycin C. Sodium thiosulfate is another drug which can be used, and it has to be used subcutaneous immediately after the extravasation. So this is the tabulated form I think it is the same drugs which we are repeating. I don't know whether it's visible or not. So about the surgical management. So the treatment of unresolved tissue necrosis or pain lasting for more than 10 days is surgical debridement. 1/3 of the extravasations progress to ulcerations. Surgical procedures are relegated to severe extravasations or to patients in whom conservative therapy has not been appropriately initiated. The procedure should consist of wide, three-dimensional excision of all involved tissue, temporary coverage with a biological dressing, simultaneous harvesting and storage of a split thickness skin graft. Once the wound is clean, delayed application of the graft is performed. Central venous access device extravasation also is known. Extravasation agents administered through a CVED is rare complication, and the recent series of 815 patients, this complication occurred in only 0.24% of cases. The solution may accumulate in the mediastinum, pleura, or in a subcutaneous area of the chest or neck. So, it is not like extravasation is seen only in the peripheral vein, it is known for CVED also. So, you have to be vigilant. Diagnosis must be based on the clinical presentation and confirmed with the imaging techniques, usually CT scan. The management includes stopping of the infusion, aspiration through the central venous catheter of as much as amount of the solution as possible. If the extravasited agent is anthracycline, dextrazoxane might be considered as an antidote, as I have shown in the beginning. Documentation, very, very important part. Each incidence of extravasation should be correctly documented and reported. Documentation procedure should contain the following items for the patient safety and for legal purposes: patient name and number, date and time of extravasation, name of the drug extravasated as well as the diluent used, signs and symptoms, description of IV access, extravasation area, management steps with the time and date. Photographic documentation can be helpful for the follow-up procedures and decision making. The patient must be informed about the scope of the problem. So the take-home message is one has to be vigilant about extravasation because it is known complication whenever we use chemotherapy. Particularly if the venous access is not proper, patient should be educated about the type of chemotherapy regime, and patient should be educated about informing the symptoms if he has any symptom during infusion. The nurses and medical staff should be vigilant to check for if the patient is complaining about some pain, irritation and redness at the site of infusion, and appropriate measures should be taken as early as possible. We should not wait for the extravasation to happen and then take the steps. So one has to be vigilant. Thank you.